Everyone, and welcome. We are thrilled to have you today for this important discussion on triaging dermatology cases and optimizing referrals. My name is Kim Montanarello from Visual DX, and I'll be your moderator for today's session. Before we dive in, I have a quick note. This session is being recorded, and we encourage you to ask questions using the Q&A feature. We intend this to be an open forum for discussion, so do not hesitate to engage. I'm excited to introduce our panelists, Dr. Jeff Moon, Assistant CMIO and Emergency Medicine Physician at Penn Medicine, and Dr. Art Papier, CEO and co-founder of Visual DX and a dermatologist. Both bring deep expertise in clinical decision support and health technology, and they'll share real-world examples of how to improve dermatology triage and referrals in your organization with the right tools. We want to note that Dr. Moon is participating in this webinar in his personal capacity. He's not representing or speaking on behalf of his employer, and his views and opinions expressed are his own. With that, let's get started. Art, I'll pass it off to you.
Thank you so much, Kim. This session is really about the dermatology shortage we have in this country, and we're going to be talking about how do we support non-dermatologists, which means all of primary care, the emergency department, urgent care, anywhere where a patient has a rash or a skin lesion and needs help. And I'm really excited to have Jeff here be part of this conversation because he really is hearing this firsthand, like what's needed in healthcare. So I'm going to turn it over to you, Jeff.
Hi, everyone. Yeah, I'm Jeffrey Moon, an emergency medicine physician. Definitely not a dermatologist, but we see a lot of rashes in the emergency department. But I also wear the hat of a CMIO role where I hear the other specialties talk about how to treat rashes, among other diseases, as well as the dermatology shortage that we have here at Penn. It's too long to get an appointment with a dermatologist. It's often 6 months. And so how do we address this clinical need, patient expectations for it? Visual DX has been really good for us, and I can share some examples. I could just start with one of our primary care examples. We had a gentleman who came into a primary care office not super long ago. I heard this from a primary care colleague of ours. It was a Penn patient in the Philadelphia suburbs who called his primary for a non-Penn dermatology referral. Patient had a new rash. He said his insurance company required the referral. And the Penn primary care doc said, I'm happy to help you. But instead of just sending the referral, knowing it's going to be a long wait, several months, why not in the meantime, I'll see you. You come in the office next week. I have an opening. It was an itchy chronic rash on his hands and feet and shins. So the patient said, that sounds good. I'll come in. Now, the primary care doc saw the rash, was not very familiar with it, but used Visual DX to help make the correct diagnosis, putting in the patient's findings, demographic information, looked at the rash that the patient had and some of the images that Visual DX shared. Very easy to use software. And it recommended in the end an antifungal for 3 weeks. And he said, oh, we'll give it a try. And he considered other medications initially, but changed following Visual DX's recommendation. 2 weeks later, the PCP had his office's nurse call the patient to check in, see how he's doing. He did give the referral, by the way. And the patient actually was happily reported the rash was gone, and he sleeps more comfortably, and he was immensely appreciative. He even said, I don't need that dermatology referral anymore. So this is really good for several reasons. When I hear this as, physician colleague of this guy, as well as with a CMIO hat, the PCP used Visual DX and his own clinical experience to satisfy the patient. The patient was happy. It prevented leakage. This patient was going to leave Penn because the wait is so long for derm, and they're very good at Penn derm, but it was a 6-month wait. So the patient leakage didn't occur. It also avoided an unnecessary derm referral to begin with, and the whole system was more efficient. So we know, that's an N of 1, right?
So
and
we
that
could break that.
represents a lot. Yeah.
I mean, we can break that problem down further, Jeff, and think about in the primary care office, there's a couple scenarios that can happen. One is that the clinician does not know what the rash is and needs the help of visual DX. But often these primary care doctors do know this is psoriasis or this is eczema, and they might need help with treatment. And furthermore, they might need help convincing the patient that they have the expertise to handle it themselves. What's your thoughts on that in terms of what are you hearing about how primary care doctors using visual DX?
Yeah,
Both?
so integrating Visual DX into the workflow was an important part of like the change management after Penn made it available to everyone. So long as it's like a resource that is in everyone's hands, it ends up being because it's so easy to use and really helps people who are non-dermatologists out as well as the dermatologists. It has really helped them out. We know about stories. It's not just about decreasing referrals to derm because some might be appropriate. Some you might have said, I didn't think this needed to go, but now I think it should, or vice versa. I don't think this patient needed dermatology. I did think they need dermatology, but now I feel more comfortable prescribing it, prescribing the right medication. Maybe they don't. Patients can actually get engaged in those situations because we have stories where the patient knows they're talking to a primary or an urgent care PA or something like that, and they know they're not an expert on skincare, but you could use Visual DX in a way where you show you see the patient's rash and you see the patient's rash. You find similar appearing rashes on Visual DX. It's got these like bright, nice color pictures, all different skin types and that kind of stuff. Really, there's no other resource that I'm aware of that's like it. And you engage with the patient and say, doesn't your rash sort of look like this one? This accordingly match the right demographics or risk factors and that kind of stuff. And they like that. Some patients really do appreciate that engagement and
I'm really glad you're mentioning that because it speaks to the transition that we're living through. 20 years ago, it would really be paternalistic. Doctor says, this is what you have, trust me. And now it's much more of a dialogue with the patient and this need to build trust and to educate the patient in the moment. And we hear this over and over again in our user surveys that how powerful it is to just pivot that monitor to the patient. And it just takes 15 seconds to say, I'm sure this is what you have.
yeah, I've had patients say I want to participate in this, like tell me why that, I heard steroids have side effects. Well, it's topical steroids, sir, it's not as many, but this is why. Don't you think that looks like the rash you have? And they look and pivot monitor just like you said, and you go, well, look, if we're all in agreement, triamcinolone twice a day for a week might benefit you. We could still, why don't we give that a try? They feel more participatory in it. So it's a patient satisfaction. So we've seen, patient satisfaction result from that type of engagement because they know, again, I'm an ED doc. I'm not an Papier. I'm not a real like dermatologist, but when I have this sort of collaborative and health technology solution, it adds to some of the trust actually that patients have with folks like me.
Well, Jeff, your job honestly is much harder than mine because emergency physicians and any generalist, primary care physician can see any of 500 different symptoms, chief complaints from patients. So you have to like adapt on the fly to, is this a serious rash or is this something that could be seen later by primary care or be seen in urgent care on the non-acute side? And that's what makes your job so difficult is, one rash might be a sign of something very serious, and one might be a sign of something that's just a normal skin condition that needs a topical steroid. So maybe you could share some user stories that you know from your experience.
Yeah, I had this one that for folks who are in emergency medicine, this is the type of one that'll scare you. heart attacks, strokes, gunshot wounds, that's more of like my type of bread and butter, but of course some severe infections and things like that. We had a case that this actually went quite sort of viral around the Penn Emergency Department when they heard about it. It was over the winter. It was a 46-year-old female Black patient who had body aches, fatigue, and fever at home. No fever in the emergency department, mild headache, midwinter, a lot of viruses going around. There was a time, if you all remember, we had both COVID and flu A was very prevalent. She seemed to fit that type of profile. And if basic infectious workup was reassuring, even a little bit of a white count bump, normal chest x-ray, urinalysis, BMP, the heart rate was still a little bit high. This is resident again, PGY2 emergency medicine resident did a thorough exam, noted nothing really focal except what was unusual is there was a diffuse faint red rash on a patient with darker skin, so it's kind of hard to see to begin with. They used the Visual DX app on the phone. There's this pretty cool, like take a picture of the rash on your phone. It's called Derm Expert, and then put in demographic information. It helps you think through your differential. Meningiococcemia was very high on the differential. She shared it with the attending. It wasn't me, it was one of my colleagues though, and they said they were not actually thinking about meningococcemia because the patient was so well appearing. They were even ready to like discharge the patient saying Tylenol, come back if you get worse. It's probably COVID or flu. We don't need to hold you for the next 4 hours for the testing results. But they actually observed the patient for longer. And it was a good thing they did because in the next few hours, the blood pressure dropped after fluids, the oral temperature spiked to 103, the rash got worse, more fluids were given, and the patient denied a headache or neck stiffness, but actually became repetitive and confused. The reason I even heard about this case is because it became a save of the month, which is kind of like this friendly competition the ED residents have. So when the patient got repetitive, confused, and febrile without a known source, this didn't look like regular flu. IV antibiotics were given, and then the blood pressure dropped again. You could probably see where this is going if you're clinical. Eventually, a lumbar puncture was performed, and it showed gram-negative bacterial meningitis. The patient was transferred to the ICU. So they said, and again, this is an N of 1. This is not a daily occurrence, but it's right at the top of folks' memory, and it's kind of a cool case, a good save, that the nudge from really the software, the Visual DX phone app, they might have missed this otherwise. And the resident kind of celebrated it and then spread. And so afterwards, you can imagine people started to, like residents who sort of weren't using Visual DX as much, that they were a little bit more. So it helps even with emergency medicine type cases. So just more use case scenarios for it.
I'm glad they're sharing that case. And it reminds me of years ago, we had an emergency physician in South Carolina that had a case signed out by the nurse practitioner as strep. And he used Visual DX at the time and discovered that the rash did not look like strep due to what Visual DX was showing, and figured out it was bacterial meningococcemia as well. So these rare cases do happen, and it really comes down to this issue of, 95% of the time these rashes are not serious rashes. But we still have this responsibility to find that 5%. Of course, it's probably higher in the ER, some of these more serious cases.
I mean, I think strategically, as health organizations increasingly integrate health technology in their workflows, it's going to be more and more reliance on, I don't want to say reliance on an external brain to make the diagnosis. It's that it augments our ability to be better clinicians. And again, I'm not a dermatologist, but this is bread and butter meningococcemia for folks like me. So we have a plan for just increased use. To me, it's like, Visual DX is absolutely worth it, high value. My bigger challenge is to have spread the word internally at Penn. Those that have used it and benefit from it, that resident who made the diagnosis, that PCP who made the diagnosis, They don't need any persuasion. Their colleagues have probably heard the stories, but even reaching out further and getting it integrated into people's workflows is the goal.
Well, obviously clinicians are really busy and it's difficult to get everybody to embrace something right away. And so that's all a change management issue in an organization. And you have this role as really in informatics. So I'm wondering if you have any insight that you'd want to
Sure.
share
So
informatics side.
yeah, we're a big what we call nudge organization, which means we try to take this philosophy in health technology as a CMIO and other folks in this space. Even if you're not a CMIO, you want to make it easy to do the right thing. You want to make it hard to do the wrong thing. And so if we think this tool is very good and it helps augment folks' diagnostic ability, decrease risk, upskill people, maybe prevent inappropriate referrals, something like that, you want to make it easy to use that tool. And so what we did is there's the 5 rights of clinical decision support that apply that really any informaticist knows the right time, the right place, the right channel, the right person. So you want to build the tool in the right place. So for Visual DX, we have in the emergency department certain workflows. We use Epic as our EHR vendor. If you're doing a derm workflow, we made linking URL to Visual DX, things like that. Derm consults with Visual DX sort of embedded in it. We put it right at people's fingertips, making it easy to find it at the time you have the patient who needs it. Of course, we did broad emails and made it easy to find on like your organization's landing page and intranet. But like you just have to rely on people's memory to go there. But if you have it when they're in their regular derm workflow, and it's kind of right there, it's more likely to be used. And it's a quality assurance that we think we're using, or our folks are using Visual DX instead of
Well,
Google.
you're raising a really important point about having a trusted information source across an organization in the flow of the record and in other touch points in the health system, because it's not always the case. I mean, there are many health systems where one clinician is Googling, the other is using a large language model, and the organization is just unsure of what the practitioners are all doing. I mean, it's just huge variation. And, our mantra is establishing high reliability, credible information that's trusted. And that's what we've been meticulous about for 25 years, is being able to say we built the world's best professional medical image collection so that a busy clinician can easily get at information, whether it's the images or whether it's concise, pithy text on treatment. And I think that's an important point that's often missed is how ad hoc and expedient the use of resources are in some institutions. And what we're doing with Visual DX at the enterprise level is making it a platform where you as an ER doctor could say to the dermatologist, said, I had a patient who I thought had this disease. I use Visual DX, and here's the link, and you're all speaking the same language. I case to me also, which is a pretty rare case. Maybe you want to share that one.
Yeah,
as well.
so I had the first case obviously was a primary care doc, which that's not me, I'm emergency medicine. And the other was a colleague of mine. I'll give you my own personal one that made me for a second think like, oh, this is how the computers take over my job. I had a patient who she had a rash that no one could really figure out, and went to the primary a few times. Primary couldn't figure out, was sent in by a community medicine dermatologist because it was progressing and it was really unclear what was happening. And I thought, oh, great, it's me, an ED doc. I got to figure this out. And the community dermatologist couldn't. So I knew I was going to consult derm, and it was the right call. But before I did, again, I used my phone, Visual DX app in the Derm Expert, and put in the patient information and took a picture of it. The patient had not much of a history, but a recent azithromycin use for like a community-acquired pneumonia. It was sort of a soft call diagnosis to give the antibiotic for. One of the top parts of the differential was serum-like sickness reaction. I have privately never seen that. I vaguely remember hearing about that in medical school. It was not on my differential. So I still consulted derm, like I said. And I called them and I said, I have a consult here in dermatology. Primary care doc couldn't figure it out. I'm no expert either. Even a community medicine physician, dermatologist didn't know. But I described the rash and I said, by the way, I use Visual DX and all derms are aware of Visual DX. And I said it came up with serum-like reaction as top. But I'm not trying to bias you too much. You figure out what you think it is. Talk to you soon. 2 hours later, after the Penn derm resident, the Penn derm whole rounding team saw the patient, they came to me, and the attending said, I think it's serum sickness-like reaction. I always started to laugh because I was like, better lucky than smart, because again, I'm not really the one who really did it. And she said, I've actually not ever seen this before. I'm certainly familiar with the disease and I'm aware of it in the literature, but the azithromycin history, the sort of the rash appearance and the other things puts that on top differential. So
Well, it's an incredibly rare diagnosis, so I'm impressed, Jeff, with your skills. I mean, we get these stories at Visual DX. It's not just physicians. We have nurse practitioners and physician assistants that use the tool. And it reminds me of a case from a few years ago of a nurse practitioner out in Oregon uh, diagnosed something called shiitake mushroom dermatitis, and I practiced 29 years and I had never made the diagnosis. And I saw the pictures and she actually did nail it. So we get these wonderful stories of, diagnosing unusual diseases. But again, for the listeners, the majority of what we see are common diseases, and the misses have to do with variation of the common. So when a patient has herpes simplex in the middle of their thigh, and the primary care doctor could easily diagnose it on the lips or genitals, but it was in an unusual location or an unusual early presentation, or as you pointed out, how difficult diagnosis can be in deeply pigmented skin. And so, obviously a picture is worth 1,000 words, and it's really about delivering that image in context, with the 5 rights and rules of informatics and doing it at the right place, the right time. So I'm wondering, as we get ready for questions from the audience, if there are any, if you have any concluding thoughts.
yeah, I would say this, at Penn, I gave a lot of positive stuff, and I'll even share a learning where we sort of made a mistake at first with the Visual DX rollout, and others should be aware that this could potentially have an the way we have it at the enterprise level, which is excellent. And at first, the communication to all the Penn docs and nurses and residents and APPs was pretty minimal, and it was from our libraries. And no one really knew they had this tool in hand. I was aware as one, part of the CMIO office, and the use or the uptake of Visual DX was sort of lower than expected. But then what I realized is that it just wasn't integrated into our workflow. So after we went live, made the purchase and that kind of stuff, what was very important to really to kind of get good ROI on this kind of thing is to work then with clinical leads, clinical operational leads, speak at a group of APPs. If there's an executive director of APPs at your organization who has all the APP managers at a once-a-month meeting, getting in front of them for just 10 minutes to say, hey, here's a great tool that's easy to use. Think of it the next time you have a rash and spread the word. Doing that kind of stuff actually was critical to getting some of these stories and some of the benefit that we wanted. It's that change management process. So just don't forget about that part.
That's a great point, Jeff. I mean, change doesn't happen just because you send one email, right?
It takes like 10.
It does. I mean, all all marketing knows that you need repeat messaging and especially to reach busy people. And we know how busy our professionals are. And I guess we should see if there's any questions. If not, we can wrap.
So we just have one question from the audience of they are on a public health system with no paid doctors or e-consults. So what are their suggestions when they don't have that readily available for them and they have a rash
I'd
that they
say
can see?
great candidate for using Visual DX because you're by yourself and you know privately, you might know your specialty that these rashes are going to come in and if it's difficult for patient, not only hard for you to make the diagnosis because you don't have that. I mean, I'm lucky. I'm at Penn. I got derm backup if I need it, et cetera, a big academic medical center. You even more want to like leverage what's fast and easy to use, but modern and that kind of stuff like a Visual DX. You also want it for the patient's perspective because their ability to get in to derm after you might even be that elusive or hard to get into. So I think you're a natural candidate then for Visual DX for it. And again, it's so fast and easy to use. It's worth the 30
Yeah,
seconds.
from the public health perspective, we're living in times now where we're having different outbreaks. Obviously, right now, measles, but we don't know what's next in terms of emerging and re-emerging infectious diseases. And in the public health environment, there's really a need for tools around, STIs. We have a growing problem with syphilis in this country. So we see a lot of use of Visual DX in the public health hospitals. We also see a lot of use in rural areas and FQHC clinics, free and charitable clinics using Visual DX because there's just not enough dermatologists, and we have to empower primary care. So, Kim, any other questions pop up
We
or?
have one more question, but it's a question actually I can answer. Do you have a video to walk through new users through some use case examples or how best to use the tool? And we do. And I would welcome you to visit our YouTube channel where we have a lot of different tutorials, both for our desktop version as well as our iPhone and Android. So, and I can send you some of that information right after this. But that's it. That's all we have for now. So thanks everyone for joining us today. As a reminder, this has been recorded and will be shared with all of you that have registered. And then if anyone is interested at all in a personalized demonstration to hear more use cases, please visit visualdx.com. We would love to be able to support you any way we can. Again, thank you to Dr. Art Papier and Dr. Jeff Moon. And thanks for you for coming here today. Have a great day.